Great. So for those of you who don't know me, my name is Micah Fisher. I run the pulmonary hypertension program at Emory University Hospital, which is actually what I do in the majority of my time. I'm not so much an intensivist, at least not this year. I was asked to speak about right heart failure, to treat or not to treat. I don't have any conflicts of interest, but I have a lot of biases, particularly when it comes to Flolan. I love Flolan. It's a wonderful drug, particularly for my patients. I'm not so sure it's a good drug for the ICU patients, so we'll talk about that in a second. We're going to define the types of right heart failure, discuss the prevalence of right heart failure in the ICU, particularly in the ARDS patient population, and review some of the suggestions in terms of therapy for those patients at this point. So the types of right heart failure. We see a number of different types, and so I want to be specific about what we're talking about for this particular lecture. There's RV failure, which is related to people who've had RV infarction. That's a pump problem and requires either a mechanical solution or an inotropic solution. Typically what we focus on mostly for that patient population is just giving them fluids. In that situation, when the RV has failed because of an ischemic issue, then you have to give enough fluid so that the right atrial pressure now becomes the filling pressure for the left side of the heart. So fluids really becomes our major focus for that patient population, more so than maybe some of the other patient populations where we'd want to be more aggressive giving fluids for RV infarction patients with RV failure. We have the acute pulmonary embolism patients, which have an obstructive problem, mechanical obstructive problem. So for that patient population, if you have true right heart failure from an obstructive process, then you have to go in and remove the obstruction. That's the key to management of that patient population. We do that either through surgical procedures, interventional procedures, or with chemicals like lytics to break down that clot and remove the obstruction. And those patients will do fine if you can remove the obstruction. We have my patient population, which is the decompensated chronic pulmonary hypertension patients, which is a completely different at least way of thinking about in terms of those patients. That's where the IV therapies come in play. We pay very close attention to the fluids and other things that are related to their RV function, how to improve their RV function. I gave a talk a couple years ago at ACCM about management of that patient population. At the time, that was the least evidence-based talk I've ever given. Today's talk is a little bit more evidence-based, but not much, unfortunately. So we just don't have a lot of evidence for how to manage the current patient population of right heart failure with ARDS. We have the post-cardiac surgery patients, something which I don't deal with very much in the post-transplant or particularly lung transplant patients where we use a lot of inhaled therapies, and I don't know the data for that. I'm not involved in that patient population very much, and I'm not going to be talking about that. And then lastly, we have the acute right heart failure patients related principally to ARDS, and that's what we'll be focusing on. This is a decreasingly common problem in the ICUs. It was first described by Septal et al. Back in 1977 in a New England Journal of Medicine article where they discussed a series of 30 patients and 100% of them had pulmonary hypertension related to ARDS. About half the patient population died in that particular series. Interestingly, the severity of the pulmonary hypertension was not a predictor of survival. What predicted whether or not you lived or died is what happened over time with your pulmonary vascular resistance. So if your pulmonary vascular resistance was elevated and remained elevated, then you had a tendency to die. If your pulmonary vascular resistance was elevated when you first came in, but it progressively improved, given that your lung function, your lung compliance was improving, then you had a tendency to live. Now, they've had a number of studies since that time looking at the prevalence, and most of the more recent studies have shown a prevalence around an order of 25 to 30%. And some of this is related to the fact that it's not 1970 anymore. We're doing a lot of things differently now than we did before, and maybe some of those things are impacting the development of significant right heart dysfunction and pulmonary hypertension. Also, we have different ways of looking at pulmonary hypertension and looking at right heart failure. So we talked earlier about the FACT trial. That was the fluid and catheter treatment trial, the ARDS network trial. That was a 2x2 factorial study looking at CVP versus PA catheters. And the second arm of that was looking at a conservative versus restrictive fluid management in that patient population. Everyone always talks about the fluid issues. Other than this morning with I think it was Annette, very, very few people talk about that PA CVP catheter and what that study actually showed. It showed, as she mentioned earlier, that there was no difference in management in terms of outcomes if you had a CVP catheter or a P catheter. And because of that, we really don't use PA catheters anymore routinely. And I think other than my chronic PH patients, I think I've floated one swan in the past 10 years, and I think most of you guys have at least in our ICU, we actually don't even remember how to use swans anymore in the ICU. We always have to have someone come up from the CCU to help our nurses hook up and set up a swan, because we just don't do it very often anymore. But Todd Bull out of Colorado took that data from the PA catheter arm of that study and was able to use it to answer some of these questions, at least give us some more insight into questions regarding pulmonary vascular dysfunction. What he found, unfortunately, he didn't come back and give us a prevalence. He didn't say 30% or 40% of people had pulmonary vascular disease. He did give a mean PA pressure, and the mean PA pressure for that 501 patients who had ARDS in the ARDS network trial, so that specific kind of research patient population who had a PA catheter put in, the mean PA pressure is around 30. So on average, people had some mild degree of pulmonary hypertension. The PA pressure itself did not predict survival. What predicted survival was that gradient from the mean PA pressure to the pulmonary artery wedge pressure, the transpulmonary gradient, which has different definitions, which I want to stress. He used the definition of a mean PA pressure minus the wedge pressure is that transpulmonary gradient. If you have a relatively low transpulmonary gradient, so think of somebody with a relatively low mean pulmonary pressure, assume they have a wedge pressure of 12, so a mean PA pressure of, say, of 20, with a wedge pressure of 12 will give you a transpulmonary gradient less than 12, or so around 8 or so. You had a pretty good survival, around 20% mortality for that low transpulmonary gradient. If in a more typical transpulmonary gradient, the 12 to 24 range, so someone kind of mild pulmonary hypertension, assuming a normal wedge pressure of around 12 or so, then you had the kind of typical 27, 28, 30% mortality we typically think of for ARDS nowadays. That was the bulk of the patients in that particular study. We had 308 patients. But there was a subset of people who had fairly severe pulmonary hypertension or severe RV dysfunction or pulmonary vascular dysfunction, defined as that transpulmonary gradient difference of greater than 24. And for that people, they had a fairly high mortality, around 47% or so mortality. But what you see here is that was only 41 people with a 501. So severe RV or pulmonary vascular dysfunction, then that's leading to RV dysfunction, is a relatively rare problem in the ARDS patient population, at least based on that study by Todd Bull back in 2010, looking at data from that study that occurred around 2002 to 2005 or so. That brings us to the French. The French have actually done the bulk of the literature on this particular area in the past couple of years. They've been very focused on looking at transesophageal echocardiography as a measure and definition of pulmonary vascular dysfunction, and they've been using the term acute core pulmonale. So acute core pulmonale is by definition RV enlargement and usually RV dysfunction in the setting of pulmonary parenchymal, usually parenchymal disease or pulmonary vascular disease. By definition, it excludes people with significant left heart dysfunction. They don't quite use it exactly that way. They use it as an RV enlargement. Is defined as an RV end diastolic area divided by the LV end diastolic area. If you have a ratio greater than 0.6, then that's considered an enlarged right ventricle. And you want to see that in combination with RV dysfunction, described as abnormal septal motion. So I'm not sure how well you can see this in the back there. This is a normal patient here, and this is the apical four-chamber view. So this is the left ventricle sitting here, left atrium sitting here, right atrium sitting here, and the right ventricle sitting here. This is, again, a fairly normal-looking right ventricle. It's smaller than the left ventricle. The left ventricle does the bulk of the work in terms of high-pressure, high-flow system. The RV is a low-pressure system, and so related to that, it's a relatively smaller chamber, smaller muscle size. This is the interventricular septum, dividing the left ventricle and the right ventricle. This is, again, a relatively normal-looking heart with normal right ventricular size, normal right ventricular function. This is one of my patients, chronic pulmonary hypertension patient, normal left-sided size. Her function actually a little bit decreased here, and this is her right ventricle. As you can see, her right ventricle is as wide, if not wider, and her area thus is bigger than her left ventricle. Her right atrium is huge compared to her squished left atrium. This is a severely decreased RV function, severely enlarged RV. This would be someone that would meet their definition for severe acute core pulmonale based on echocardiography. If you look at the parasternal short axis view, you have the left ventricle sitting here. The left ventricle is a nice donut-shaped ventricle here. This stuff flapping here is the fish mouth of the mitral valve. And the right ventricle actually sits here. It's a little bit hard to see, because again, this is a relatively normal person, so the RV is a really thin-walled structure. It's kind of small up and off to the side, this concentric-shaped thing off to the side of the left ventricle. This right here is the moderator band, nice bright moderator band for him. And this is, again, my patient with the left ventricle here. So you can see the huge difference in the left ventricle, normal circular donut-shaped left ventricle, completely squished left ventricle here. So this is that RV dysfunction definition they're using, not the area here, but the RV dysfunction as interventricular septal flattening, or sometimes you read reports where they describe D-shaped LV chamber. This is the D that you're talking about as opposed to the normal donut of the left ventricle. And she has this nice huge right ventricle here and a small pericardial effusion. So this is what we're talking about when it comes to echocardiographic measurements and definitions of acute cor pulmonale. So interestingly, they did some, one of their early studies they looked at was the difference in terms of sensitivity and specificity of defining this in people with ARDS based on whether or not you did a transesophageal echocardiogram or a transthoracic echocardiogram. And so they published data on a series of 200 patients who were being evaluated, and their protocol in France at these, I think it was 4 or 5 different hospitals that are part of this consortium that are very interested in this process, is to do a transesophageal echocardiogram within 3 days of someone presenting with ARDS. They apparently have readily available transesophageal echoes in their ICU, something which I couldn't get in my ICU if I wanted it. But with TEE, they felt they had 100% adequate imaging, but only 62% of the time could they actually see the RV well enough to make a call with transthoracic echocardiography. With TE, they described the incidence or prevalence of 22.5% of acute cor pulmonale in the ARDS patient population. So their argument and some of the literature they published is suggesting that we should be doing transesophageal echo given this data. You know, in my experience, we get a lot of echoes in people with ARDS, and any reason why they're in ICU. It seems like every time they sneeze, we get an echocardiogram nowadays. And never, or very rarely ever get a report back that they just couldn't see the RV well enough to give me a comment about RV size or RV function. They may not put in a report, which is a separate problem, but at least they can get good enough images that I can go down to the echo lab and look at it myself and see the RV's doing just fine and not having a problem. So I'm not sure I agree with the recommendation to do a TEE on everyone within 3 days, but I think it's reasonable to do an echocardiogram and look for some of this stuff and just do a regular transthoracic if you have concerns about RV function. So the real question is, does acute cor pulmonale increase mortality in ARDS? So they published this prospective study on 752 patients with relatively severe ARDS, defined as a PaO2-FiO2 ratio of 115. Again, everyone in their cohort, because their practice to do a transesophageal echocardiograph within the first 3 days. And what they found is a fairly high prevalence, around 22, 23%. Again, not super high, but not super low, of people with evidence of RV dysfunction, defined again as an RV end-diastolic volume, RV end-diastolic area divided by the LV end-diastolic area of 0.6. But if you just take all the patients who have that echocardiographic definition, there's no difference in mortality if you have that problem or you don't have that problem. So you can do a lot of echocardiograms, you're going to see a lot of RV dysfunction and RV enlargement, but it doesn't mean anything in terms of overall survival. I think more importantly is there's a smaller patient population that have severe acute cor pulmonale, defined as this RV to LV end-diastolic area ratio greater than 1. So when the RV is now bigger than the left ventricle, then you actually have a significant impact on mortality with 57% mortality in that higher arm versus 42% of people without evidence of that. But that only occurred in 54 or 7% of the patient population. So acute, severe cor pulmonale is a fairly rare process, this process that we're worried about because it actually has impact on patient survival. When they went back and looked at what sort of factors predicted whether or not you developed acute cor pulmonale, the presence of pneumonia as the underlying cause of ARDS was an important factor. The driving pressure, the difference between your plateau pressure and PEEP of greater than 18 was an important risk factor. A PaO2-FiO2 ratio of less than 150, and the presence of significant hypercarbia defined as a PaCO2 greater than 48. If you had 3 of these and you had a 34% chance of acute cor pulmonale, and if you had all 4 of these and you had a 74% chance of acute cor pulmonale. So the argument would be that if you are worried about this, you think about this, then you probably only need to do echocardiography in the people who have 3 of these risk factors. And if you only have 1 or 2 of these risk factors, it's probably not worth it because the chance you're going to find, or at least the chance you're going to find severe acute cor pulmonale, something you may want to take some action about, is relatively low. So let's step back a minute and think about what happens when you take someone with ARDS and put them on a ventilator. Positive pressure ventilation has a significant impact on RV function. It does this through a whole number of ways. Some of the important ones is that it decreases venous return to the heart. As you increase pleural pressure, you decrease venous return back to the heart. As you increase transpulmonary pressures, you actually increase afterload in the right ventricle, which is probably the predominant issue that we're dealing with here. And also, the inadequate lung recruitment or overdistension can also both increase afterload. So if you remember back to basic pulmonary physiology, when the lung is at FRC, at functional residual capacity, the pulmonary vascular resistance is at the lowest. As you take a deep breath in and you stretch those small alveoli in your lung, you actually stretch the small capillaries around the alveolus as well, increasing pulmonary vascular resistance in that circulatory bed. At the same time, if you go from FRC and exhale completely, in that regard, you now allow those alveolus, as even get small, the capillary bed around it have more room and less resistance. But the larger vessels that are between the alveoli and in the lobar areas are no longer being stretched by the elastic recoil around the heart, around the lung. So you actually have increasing pulmonary vascular resistance in those larger vessels as you exhale, and you have increasing pulmonary vascular resistance in the smaller vessels as you inhale. So again, your pulmonary vascular resistance is its lowest when you're at FRC, and it gets worse either you exhale or inhale from that point on. Same thing happens with if you put someone on positive pressure ventilation. As you overdistend and make those functional alveolar units bigger and bigger, that actually creates increasing pulmonary vascular resistance for that part of the microcirculatory bed. And if you allow a part of the lung to become collapsed atelectatic, that part of the vascular bed actually has increased pulmonary vascular resistance as well. So either over distension or inadequate recruitment of the lung causes increasing pulmonary vascular resistance, and thus an increase in afterload in the right ventricle, and leads to RV failure. At the same time, hypercarbia through permissive hypercapnia and the acidosis that we typically see with that, all those also have direct impacts on pulmonary vascular resistance, increasing them. So whatever we do with a ventilator, we need to try to minimize these impacts that it has on the right ventricle if we're worried about acute cor pulmonale. At the same time, as I showed you before, with someone with a significant RV distension, it's compressing the left ventricle. So the RV and the LV work in series and in parallel. In series, in essence, because the LV can only pump what the RV gives to it, a point which is lost in some of the cardiologists I talked to. It was like, well, the LV is fine. I don't know why the cardiac output's low. Well, the RV is not, guys. The RV is very dysfunctional, and the LV can only going to pump how much the blood the RV can give to it. At the same time, as the RV becomes larger and larger and larger and compresses the left ventricle, it impedes left ventricular diastolic volume or left ventricular stroke volume, reducing cardiac output as well. So we have to use or be judicious with our fluids, minimizing RV dilatation. So being very, very cautious with the fluids, targeting a low CVP, and I do mean a CVP because I'm worried about what the filling pressure is of the right ventricle, not what's the filling pressure of the left ventricle, actually improves RV function. There's been a number of animal and physiologic studies where they've taken hearts and they've you put a clamp around the pulmonary artery, and you see what happens as you fluid load or fluid unload the RV. The RV is better off when it's relatively fluid unloaded as opposed to fluid loaded. So giving more fluid than someone who's having acute RV dysfunction and not doing well and hypotensive, that fluid can't get over to the left side of the heart and help the left side of the heart. What it actually does, it just causes the RV to become more and more distended, compressing the left ventricle more and more, and actually compounding the issue. So diuresis in these patients can be very, very important. So excessive fluid administration can actually drive some of the RV dilatation and actually impair RV function some more. So the question for me is, should we treat acute cor pulmonale? And the answer is, well, yeah, if it's causing problems. It's probably only causing problems as people who have severe acute cor pulmonale based on the higher mortality and seeing that patient population. And I would go on one step further as above what the expert opinion articles say about this, but it's not just a matter of seeing what a dilated RV on echocardiography, but you need to have some other evidence of in-organ dysfunction, either hypotension, lactic acidosis, kidney dysfunction, something else that's contributing that you can thus blame the RV dysfunction as precipitating. Just the fact that you got an echocardiogram and you say, well, the RV is low dilated, big whoop-de-doo. We have lots of people, lots of people have RV dilation, but it's not impacting other organ dysfunction, then why bother to do anything about it? The real question, though, then is how do we treat acute cor pulmonale? This is, again, all expert opinion. There is no evidence, any randomized controlled trials to base this on, but we think that being careful how we use the ventilator is probably an important component to this. So reducing the driving pressure, targeting low tidal volumes, limiting hypercarbia, consider proning, and again, as I mentioned before, the judicious use of volume resuscitation. So I think it was 2 years ago, we had the pleasure of Dr. Roy Brower come and give a long talk regarding the driving pressure and how that is related to survival and ARDS. I'm still not sure I understand all the statistics about how they came up with this, but the physiology makes sense that if you can adjust your PEEP in a way that limits the driving pressure, then you're essentially getting optimal PEEP. You're not going to overdistend the good lung. You're not going to allow inappropriate de-recruitment of the bad lung. So by adjusting our ventilator settings to optimize driving pressure, given that that's a risk factor for acute coronary pulmonary, and then we have some evidence for this that improves survival, makes rational sense. We have other data now that suggests that proning people has improved survival. And before they came out with this article, they actually looked at RV function in people who are being proned. And what they found is people who had, at the time of ARDS before proning, had an RV to LV area, that ratio we talked about, 0.91 on average. This is a small study of 21 patients who were subjected to 18 hours of proning. So your RV-LV area was 0.91, so elevated, almost that definition of severe acute pulmonary. Just by the mere fact of proning them for 18 hours, had a significant reduction in RV area, close to almost what would be considered normal RV size at 0.61. The eccentricity index is a research tool of how to measure how much that LV is being squished by the RV. So we basically take a vertical axis through the LV divided by the horizontal axis. If you have a nice circular LV, then that horizontal to vertical axis ratio was normal at 1. If as your LV gets more and more squished and the vertical axis remains whatever it was, now the horizontal axis becomes smaller and smaller, so your eccentricity, that top number or the bottom number, gets higher and higher and higher. And so what you see is you have an eccentricity index of 1.5, so a squished LV now becomes almost normal at 1.1 just through proning. So we have a number of lines of evidence that suggest that proning people improves survival, improves RV function. So if you have people with significant acute pulmonary that you're worried about, then maybe you need to be thinking even earlier about considering proning for that patient population. The last thing I was asked to talk about is pulmonary vasodilators and what their role is. And really, at this point, we really don't have a good answer as to what to do with these agents. As you all know, there has been no specific indication, there's been no specific study looking at inhaled nitric oxide in the patient population of RV dysfunction. This has only been studied in people with ARDS. All of those studies have essentially been negative. And in some of the either Cochrane analysis or meta-analysis looking at combining all those studies and seeing if there's any evidence for a signal for improved survival, it's actually shown the opposite. If anything, you would look at this and say, well, it may be a trend towards harm with use of inhaled nitric oxide in people with ARDS. More interestingly is when you look at renal function in people who are subjected to inhaled nitric oxide for the treatment of refractory hypoxemia ARDS, there's actually a clear signal here of increasing kidney dysfunction in the patient population. It really makes you wonder why people are still grabbing inhaled nitric oxide off the shelf as a salvage therapy when there really is zero data that says it does anything good. And if anything, there's data here to suggest it actually worsens kidney function. When people have now jumped on the bandwagon from going from inhaled nitric oxide to inhaled prostacyclin, there is zero data that I can find for that. There is one clinical trial in clinicaltrials.gov. It was from Pakistan in 2009. The Cochrane Review people who tried to get hold of those results back in, I think, 2013, contacted those investigators, and they said they were still looking at the data. That was 4 years after the study was done, and it was just a crossover study of looking at hemodynamics before and after inhaled prostacyclin. At this point, I'm pretty sure we're never going to see that data. So we probably will never really know, at least at this point, and I don't see any trials that are listed as in process or looking at evaluating inhaled prostacyclin for RV dysfunction ARDS. So we may never know. But if the idea and the argument is that inhaled prostacyclin is just a cheaper form of inhaled nitric oxide, then again, why are we doing this when we don't have any evidence that actually makes any impact on our patient population? Again, a lot of these ARDS studies for nitric oxide were done in the era where we were still using relatively high tidal volumes. And so that if it was going to work, it was probably going to work back then when we were doing more deleterious things with the ventilator. Now that we're doing better things with the ventilator, it's unclear really what benefit it offers our patient population. So in summary, right heart dysfunction is really not super common, 22-25% of the patient population, but only the severe form, which affects less than 10% of people with ARDS, Is it actually associated with increased mortality? Our approach in the expert opinion papers you find about this all focuses on what we're doing with the ventilators, because that's what seems to be the biggest risk factors for going on to develop significant acute coronary pulmonale. And so what we're doing with the ventilators, what we're doing with the fluids, based on all these other trials, is telling us what we should be doing for this patient population. And at this point, there's no data to support use of inhaled therapies. And with that, I'll take any questions.